Welcome, everyone. Get incredibly comfortable, and thank you so much for joining us today.
Yeah, it's really great to have you here.
We have a fantastic discussion lined up for you. But real quick, before we jump into the material, we do have a tiny favor to ask.
It's a small one.
If you haven't already, please hit that subscribe button on our YouTube channel. We are going to be dropping a lot of exciting new videos very soon, and you absolutely want to be in the loop for those.
You really do. And head down to the comments, too.
Yes, please?
Let us know what you want the title or topic of our next deep dive to be. We are building this show for you, so your suggestion could literally be our next big topic.
Exactly. We truly value that interaction. The goal is always to make you feel like you are sitting right here with us, unpacking the details of something you thought you fully understood.
Only to realize there is a whole hidden world beneath the surface.
Today, we are relying on a remarkably detailed stack of medical lecture notes. It's titled literally just appendicitis.docs.
Which is such a classic file name.
Right. And our mission today is to decode the ultimate medical mystery of the right side of your abdomen. We are talking about the vermiform appendix.
We're going to explore why this tiny organ causes so much trouble.
Because it is the leading cause of the acute abdomen in young adults, right?
Exactly. And we'll look at how doctors actually figure out what's going wrong. Plus, why everything you thought you knew about it being just a useless leftover is completely wrong.
Okay, let's unpack this.
The best place to start is with that exact myth, I think. For generations, the medical consensus treated the appendix as just a vestigial organ.
Like a biological liability.
Right, just sitting there waiting to explode. The assumption was that it served no physiological purpose at all.
But the notes highlight something totally different.
Yeah, it actively participates in the body's immune system. It actually contains significant lymphoid tissue.
So it's essentially a safe house for your gut microbiota.
Exactly. Think of it like a backup drive for your gut. When your digestive system gets completely flushed out by a severe gastrointestinal illness, the appendix steps up.
It repopulates the gut with all those beneficial bacteria.
Yeah, which is vital.
And there's a fascinating immunological relationship mentioned in the text, too. Having your appendix removed actually appears to be protective against ulcerative colitis.
Which is a really severe inflammatory bowel disease.
It's wild. It implies the appendix is such an active immune powerhouse that taking it out somehow alters the entire autoimmune response in the colon.
It really demonstrates how intricate the GI system truly is. But to understand how things go wrong, we first have to map out the anatomy.
Paint us a picture.
So the appendix is a blind-ended muscular tube. It averages about 7.5 to 10 centimeters long.
So pretty small.
Yeah, and it extends off the cecum, which is the very beginning of the large intestine.
Now, for surgeons, locating it isn't always straightforward, but they do have a specific roadmap, right?
They do. The base of the appendix is anatomically constant. You will always find it at the exact convergence of 3 longitudinal muscular bands on the colon.
The Taenia coli.
Exactly. So surgeons find the anterior Taenia coli and just trace it downward.
Like following a highway straight to the base.
Straight to the appendix base, yeah. But while the base is fixed, the tip is incredibly mobile.
This is where the Wakely classification comes in, right?
Yes. In 74% of people, the appendix is retrocecal. That means it curves backward and hides completely behind the cecum.
So almost 3/4 of the time it's hiding.
Yep. And in another 21%, it dips way down into the pelvis.
And the notes also mention a brilliant clinical pearl about intestinal malrotation.
Oh, yeah. That is a nightmare for diagnosis.
During fetal development, the intestines are supposed to rotate and fix into a standard position. But when that fails, a patient can end up with their cecum and their appendix on the left side of their body.
Imagine being an emergency physician dealing with a patient who has sharp left-sided pain.
You would never immediately think appendicitis.
Never. It forces the doctor to rely heavily on imaging rather than classical physical presentation.
Here's where it gets really interesting. Why does this tiny mobile organ suddenly become a massive medical emergency?
It comes down to demographics and anatomy. The peak age for acute appendicitis is in teenagers and young adults in their early 20s.
Which ties directly back to that immune function we talked about.
Exactly. The submucosa of the appendix is packed with lymphoid tissue, and that tissue reaches its absolute maximum size and activity during those specific years.
So the tissue is at its max volume, meaning the internal space or the lumen is incredibly narrow.
Very narrow. And the initiating event for appendicitis is almost always a luminal obstruction. The exit just gets blocked.
What blocks it?
A few things. It can be lymphoid hyperplasia, where a standard viral infection just causes those immune tissues to swell up and seal the tube shut.
But it's also tied to our diets, right?
Yeah, modern low-fiber Western diets are a big culprit.
Because the lack of fiber slows down transit times, leading to a phacolith.
Right. A hardened, calcified piece of fecal matter that lodges perfectly into the base.
The notes also mention a incredibly bizarre trigger, parasites.
Oh, the pinworms.
Enterobius vermicularis. They can literally migrate into the appendix and cause a physical blockade.
Which is horrifying but true. And what's fascinating here is the precise cascade of destruction that follows that blockage.
Walk us through it.
Once the lumen is obstructed, the mucosal lining doesn't just stop working. It continues to secrete mucus at a totally normal rate.
But the fluid has nowhere to go.
Nowhere at all. So intraluminal pressure begins to rise dramatically.
The pressure pushes outward against the walls.
Yes, and this compression initially collapses the tiny lymphatic vessels and the venules.
So blood is still pumping in through the arteries, but venous blood cannot drain out.
Exactly. The whole organ becomes severely edematous. It swells up with trapped fluid and blood.
And this highlights a fatal anatomical flaw.
The end artery problem. The appendix relies entirely on the appendicular artery for its blood supply. There is no collateral circulation.
Meaning there is no backup route if that single artery gets blocked.
Right. So as the pressure inside the appendix exceeds the arterial pressure, the blood flow simply stops.
Ischemia sets in. The tissue is literally starving for oxygen.
And once that tissue becomes ischemic and starts to die, the mucosal barrier breaks down entirely.
And the appendix is full of bacteria.
Tons of them. Aerobes that need oxygen and anaerobes that thrive without it. They aggressively invade the dying wall.
Transitioning it into gangrenous appendicitis.
Yes. And if a surgeon doesn't intervene, that necrotic wall ruptures.
Spilling highly infectious bacteria and fecal matter directly into the sterile peritoneal cavity.
Which is life-threatening peritonitis.
But the body has a wild defense mechanism against this rupture. The lecture notes call it the abdominal policeman.
The greater omentum.
Yes, an apron of fat hanging from the stomach.
When the appendix gets severely inflamed, this structure actually senses the localized infection. It physically migrates to the right lower quadrant.
It moves.
It moves and wraps itself tightly around the inflamed appendix.
Along with nearby loops of small bowel sometimes.
Right, trying to wall off the infection and create a contained abscess instead of letting the bacteria spread everywhere.
It is a remarkable physiological response.
Right.
But knowing what happens on a cellular level is one thing. Translating that to a patient in an ER is a whole different challenge.
It really is. Despite having CT scans and ultrasounds diagnosing this is still primarily an art form.
It's rooted heavily in clinical examination.
The absolute cornerstone of that is the classic Murphy's sequence.
This is the specific shift in how the patient feels pain right.
Yes, driven by the nerve supplies.
Yeah.
The pain rarely ever starts in the lower right quadrant.
It typically begins as a vague, dull ache near the umbilicus or the belly button.
That's visceral midgut pain. The autonomic nerves for the appendix enter the spinal cord at the T10 level.
So early swelling just registers as a poorly localized central distress.
But as the inflammation worsens and spreads through the full thickness of the wall, it starts to irritate the parietal peritoneum.
That's the highly sensitive lining of the abdominal cavity.
Exactly. And because that lining has somatic sensory innervation, the brain can suddenly pinpoint exactly where the irritation is.
So the pain rapidly shifts to the right iliac fossa, and it becomes sharp and severe.
That visceral to somatic shift is the classic gold standard indicator.
However, the notes introduce a big caveat, the 50% rule.
Yeah, that textbook pain shift only happens in about half of all proven appendicitis cases.
So clinicians have to rely on secondary rules, like the nausea rule.
Which states the abdominal pain must come before the vomiting.
If a patient vomits first and then gets abdominal pain later, it's likely gastroenteritis or food poisoning.
Then there's the hungry child rule. Anorexia or a total loss of appetite is highly sensitive for this.
So if a sick child comes in complaining of stomach pain, but they willingly ask for a snack, the doctor should question the diagnosis.
The likelihood of it being acute appendicitis drops significantly in that case.
And the physical exams they use to confirm this have an incredible historical legacy.
Oh, the eponyms are everywhere, like McBurney's point.
Named after Charles McBurney. It's the specific spot of maximum tenderness, exactly 1/3 of the distance from the anterior superior iliac spine to the umbilicus.
And we also see the influence of Reginald Fitz, who originally identified the pathology way back in 1886.
But because the appendix is so mobile, like we mentioned, just pressing on McBurney's point isn't always enough.
If the appendix is retrocecal, it's padded by the gas-filled cacum. That masks the tenderness completely.
So doctors use Rovsing sign. Deep palpation on the left side of the abdomen pushes gas back through the colon.
Distending the cacum and triggering a sharp pain on the right side.
They also use the psoas sign. By asking the patient to extend their right hip, the psoas muscle flexes against a retrocecal appendix.
Causing sharp pain. And for a pelvic appendix, they use the obturator sign.
Internal rotation of a flexed hip irritates the organ resting against the obturator internus muscle.
These signs are crucial because clinicians are constantly dealing with false leads.
If you imagine being an ER doctor for a minute, you are looking at a puzzle where the answers keep changing based on the age and gender of your patient.
The appendix is famously called the Great Mimic.
Let's talk about those demographic traps. Young boys present a very unique danger.
The scrotum rule.
Yes, right? Iliac fossa pain in a boy must be considered testicular torsion until definitively proven otherwise.
Torsion cuts off the blood supply to the testicle, causing ischemia, and that pain radiates straight up into the lower abdomen.
Missing that while hyperfocusing on the appendix can cost the patient a testicle in a matter of hours. Doctors always have to check.
Then you have infants under 36 months. They present a different challenge because they just can't articulate the Murphy's pain sequence.
They can't describe the shift.
Which leads to massive delays in diagnosis. That's why infants have the highest rates of perforation.
A fever over 38.5 degrees Celsius in a toddler is rarely simple appendicitis, right?
Right. It usually indicates mesenteric adenitis.
Which is just swollen lymph nodes in the abdomen following a standard sore throat or viral infection.
Another huge mimic in kids is intussusception.
Where a segment of the bowel essentially telescopes into an adjacent segment.
It cuts off the vascular supply, shedding mucosa and blood to create that classic red currant jelly stool.
Moving to women of childbearing age, they are considered the ultimate diagnostic trap.
Because the female pelvis houses multiple structures that perfectly mimic appendiceal pain.
It could be pelvic inflammatory disease.
Or Mittelschmerz, which is that localized pain some women feel when a follicle ruptures during ovulation.
But the most lethal mimic here is an ectopic pregnancy.
Absolutely. If an embryo implants in the right fallopian tube, it will eventually outgrow the space and rupture the tube,
causing a massive internal hemorrhage. This is why there is an unbreakable rule in emergency medicine, a mandatory pregnancy test for every single female in this demographic.
No exceptions. And at the totally opposite end of the spectrum, you have patients over 60.
Their symptoms are notoriously vague.
The elderly immune system doesn't mount the same aggressive response. They might show up with a normal temperature and normal white blood cell counts, even with a gangrenous appendix.
It could be diverticulitis, a bowel obstruction from colon cancer, or an actively leaking aortic aneurysm.
Which creates a golden rule for the elderly. Never rush an over 60 patient to surgery without a CT scan.
You have to map the exact pathology first. This brings us to the actual decision-making. How do doctors synthesize all these symptoms and traps to make the final call?
They use the Alvarado score guided by the mnemonic Mantrals.
Mantrals breaks down the clinical picture into points. M is for migration of pain. A is for anorexia. N for nausea.
T is tenderness in the right lower quadrant. R is rebound tenderness.
And then the lab work. E for elevated temperature. L for leukocytosis. And S for a shift to the left.
For anyone not reading blood smears every day, a shift to the left just means the bone marrow is reacting to a severe infection.
By dumping a ton of immature white blood cells, specifically neutrophils, into the bloodstream before they are fully ready.
A total Alvarado score of 7 or higher means surgery is indicated.
If it's a 5 or 6, imaging becomes the tiebreaker.
Ultrasound is great for kids and thin adults to avoid radiation.
But the CT scan is the 95% accurate gold standard.
But a confirmed diagnosis doesn't always equal an immediate trip to the operating room.
Really? Can it be treated without surgery?
Yes. Uncomplicated cases can actually be managed conservatively. A strict regimen of complete bowel rest and intravenous antibiotics.
Like a combination of cephalosporin and metronidazole.
Exactly. And that has an initial success rate of about 85%.
The catch is the recurrence rate. About a third of those successfully treated patients will get appendicitis again within a year.
There is also a highly specific conservative protocol called the Ochsner-Sharon regime.
This is for patients who show up to the ER late, right, after a few days of symptoms.
By the time they arrive, the greater omentum has already succeeded. It's wrapped around the appendix, creating a palpable, localized inflammatory mass.
Operating on that is incredibly dangerous.
The tissues are friable and easily torn. You risk damaging adherent loops of small bowel or creating a fecal fistula.
So instead, they admit the patient give IV antibiotics and actually trace the mass on their abdomen with a marker.
They monitor pulse and temp meticulously. If the mass shrinks, they let the inflammation resolve entirely before considering surgery.
But there's a massive warning flag with this approach. The over 40 rule.
If you treat a patient over 40 conservatively, they absolutely must get a follow-up colonoscopy a few weeks later.
Because the initial blockage might have been caused by an undiscovered cecal tumor.
Right. Cancer risk increases with age.
So what does this all mean when surgery is the only option?
Laparoscopic surgery is the modern gold standard. Keyhole surgery.
They use a camera for a magnified panoramic view, especially crucial for female patients to directly visualize the ovaries and rule out those mimics.
They locate the Tania coli ligate, the appendicular artery, to stop bleeding and extract the organ.
But the notes conclude with a fascinating surgical paradox. What happens if they go in and find a perfectly healthy, normal appendix?
They do not just stitch you back up, they remove it anyway.
Which sounds wild, but the logic is completely focused on future risk mitigation.
If they leave it, the patient wakes up with surgical scars in their right lower quadrant.
10 years later, if they get right-sided pain, a new ER doctor will see the scars and assume the appendix is already gone.
Taking it completely off the differential diagnosis.
So to prevent that trap, they remove the healthy appendix to ensure the physical scar matches the internal reality.
And while they are in there, they check the surrounding bowel for the true cause of the pain, like Crohn's disease.
It perfectly illustrates how surgery is about long-term patient care, not just immediate mechanical fixes.
It's an unbelievable physiological story. We've gone from treating it as a dead end to realizing it's an active immune participant.
We've seen how its narrow lumen and single artery make it uniquely vulnerable to perforation, making it the focus of urgent abdominal surgeries worldwide.
And identifying it still relies so heavily on classical clinical medicine, mapping pain shifts, interpreting physical signs, and dodging brilliant mimics. If we connect this to the bigger picture, there is a profound question lingering here for all of us.
Yeah.
We now know the appendix actively maintains our gut microbiome and protects against conditions like ulcerative colitis.
So what are the invisible, systemic, long-term consequences for the millions of people who had their perfectly healthy or only mildly inflamed appendix preemptively removed decades ago?
If we routinely extract an immune powerhouse, what subtle changes are happening in their bodies over a lifespan?
That is an incredible thought to end on. The true long-term ripple effect of a procedure we have completely normalized.
It really makes you think.
A massive thank you to everyone for joining us on this deep dive. Please remember to subscribe to our YouTube channel so you are the first to know when our new videos drop.
And seriously, jump into the comments and drop your suggested titles for our next topic.
Until next time, keep your curiosity alive, stay comfortable, and we will see you on the next deep dive.